Hello, good afternoon everyone. Welcome to the sixth and final module of our webinar series on facilitating large-scale change. I'm Ian Smith, Programme Lead for Improvement Methodology in NHS England's Sustainable Improvement Team. I'm MC and host for today's webinar. I've got with me again Rachel Gray from the SI team. Rachel will be supporting the interactive sessions of the webinar and looking after all things technical for us. Please do get in touch with Rachel via the chat box on the bottom right hand side of the screen if you do need any help or support. And joining us today we have got Samantha Riley, Head of Improvement Analytics at NHS Improvement, and Alison Johnson, Measurement and Evaluation Manager, again in NHS England's Sustainable Improvement Team. Samantha's worked for the NHS for over 20 years in a variety of improvement and transformation roles, including in NHS England, where she led the national rollout of the Friends and Family Test. And Samantha, as we will soon find out, is very passionate about the use of data to support improvement, and as a self-confessed information junkie, it says here. Alison is an analyst and statistician. She's worked in healthcare for over 15 years in various programs and various parts of the system. Alison loves numbers and even has a favourite chart named after Italian economist Vilfredo Pareto, who incidentally also shared Alison's passion for gardening. Not often you get an intro like that, Alison. And today, Samantha and Alison will lead the session, which is going to focus on measurement and large-scale change. And hopefully what we'll help you do is to think about how you can use and present data, introduce some concepts around measurement for improvement, look at the different phases of measurement and how they differ. And we'll do a little bit around defining different types of measures and some approaches that might be useful for using measurement within your large-scale change approaches. So I think Samantha is starting us off, so I will hand over to your good self, Samantha, to get us underway.
Thank you very much. Hello, everybody. Thanks a lot for asking me to talk to you about measurement for improvement, which is something that I am very passionate about, as Ian's already alluded to. So this is me holding the Olympic torch. And the thing that I wanted to start by saying is I was a participant in the first Academy for Large-Scale Change, and if I hadn't have gone through that programme, I wouldn't have been in a position that I would have been holding this torch. And I'm going to talk to you a little bit about what a profound experience the Academy had on how I basically do my work. Just a little bit of additional background to say that I'm not an analyst or a statistician or an economist. My background is improvement, and I'm really passionate about data because you can't do good improvement unless you've got good data, because we need to be focusing on the right things and we need to be evidencing that the changes that we're making are having an impact. So going back to the Olympic torch story, so this is Adam. So Adam was a member of my team, and he was lucky to actually be an Olympic torchbearer. I think that there were about 20 NHS torch-bearing positions, and Adam was lucky to be able to achieve one of those. So you will, of course, be very familiar with the large-scale change model. For me, I'm not an academic person. This model worked really well for me. It kind of reinforced much of what I already knew. It released me from various constraints that I'd felt before, I think, and it was just a really practical model that had a big impact in terms of how I worked. So for me, I'd always tried to find the right hook to kind of sell a concept to people. So the idea of reframing issues in a different way for different people, I was already doing, but to know that that was a good thing to do was really powerful for me. To be able to continue on even in the face of people not necessarily supporting your change efforts, persisting in keeping the faith was a key thing that the model reinforced for me. And maybe one of the most important ones for me was to not sit around and do an action plan or a PID that's going to take months and months on end. It's about let's actually start doing something. And by actually delivering analytical products, which was my role at the time working out of an SHA, actually giving stuff out to the service, we created a lot of success and additional momentum. So we weren't sitting there writing massive action plans, we were getting on and doing stuff that made a difference. As a team, we did have a lot of fun and celebrated success, and I would encourage you to all do that because I think that there's a massive power in terms of having fun and celebrating when things are working well. I did become much more effective in terms of strategic networking as a result of going through the Academy programme. So it gave me permission to be me. It did enable me to consider much more political opportunities and consequences. And a term that was used a lot in the first Academy programme was talking about being adept at boarding the train. So jump on whatever thing is the thing of the moment and try and sell your large-scale change effort on the basis of that being part of that priority area. And I'd say be brave about what you're doing and shout about it. So don't be shy doing great work. Be brave and talk about actually what you're trying to do and what you've achieved. So in terms of how Adam ended up being an Olympic torchbearer, he took the initiative to develop a dashboard where the people working at the SHA could collect their exercise data, presenting it in a nice way using control charts that we're going to come on to a bit later. And as a result of that, he was nominated as an SHA rep and got to be a torchbearer. And I honestly think that if I hadn't have gone through this programme, we wouldn't have been successful as a team, and I wouldn't have had people that were brave and took the initiative to do different things. So massive impact in terms of how I still work today, and we're going to come back to that a little bit later. So let's start off with a little bit of interaction. So what I would like you to do is to type some words into the chat box in terms of what happens when people see this kind of data. What do people do? What do you think about it when you see data presented in this way? So start typing, people. Yeah, falling asleep, that's a good one. And I still see lots of data presented like this. I don't know if that's the experience of people on this call. Having been round and about the country doing various presentations recently, the message that I'm hearing is that we do still see a huge amount of data that is presented in this way. Scribble on it. That's a good segue into what I've seen people do. People sit around and they start circling numbers, and they are probably circling different numbers. It might be the biggest number, the smallest number, the number that's changed the most since the previous month. My experience is that this does not support a useful discussion or end up in terms of any useful action. There's a lot of time wasted. Okay, and how many times do we see data presented like this? So this time what I'd like you to do is to go to the megaphone icon. And do you want to give me a tick if you are seeing a lot of data presented in this type of format now? So it's got an additional element in terms of colour. This is presentation that I see a huge amount. If you look at most trust board reports, this is the kind of information that you'll be seeing, or pretty much any report that's published. And I would suggest that this is actually a dangerous and unhelpful way to look at your data. Let's look at one example. So here we've got A&E performance data. It's looking at April 1 year compared to April the following year. Now, can you type into the chat box what you conclude when you look at data in this way? So 1 month, 1 year compared to the same month the following year. That's performance against the 4-hour standard. Well, I can't see anything coming through. Maybe you're not concluding anything from this data, which would be it will have gone up or down. Meaningless. Okay, I'm liking the comments that are coming through here. I've presented this to quite a lot of audiences, and quite a lot of individuals within the sessions that I've run say, well, the performance has got worse. Now, it's great because it clearly shows that you know a lot more about data than the people that I've been presenting to before. We're looking at 2 data points. We're not looking at data over time. And the reality is, of course, we could look at data in that way. So if we looked at data over time, so this is the monthly performance data, and here I've identified the 2 data points in question that are in the previous graph. I would suggest that we see a very different story here. So this is a statistical process control chart. How many people are familiar with SPC? Do you want to give me a tick in the megaphone box if you are familiar with it, and a cross if you're not familiar with that? Okay, we've got some ticks, that's fantastic. So Alison's going to cover in a bit more detail later the kind of technicalities around statistical process control. The point that I just want to make is that it's actually a really simple and powerful way of looking at data. On this graph, we can see a blue line at the top and a green line at the bottom. That shows what's normal in terms of this system and how they're delivering A&E performance at the moment. So if we were looking at 2-point comparisons, we might be overreacting to data. We might be going, oh my God, that data point went down last month. Let's investigate. Let's go and develop an action plan. Let's find out what went wrong. If we're using SPC, we can understand what is normal and to be expected in terms of variation. There are rules that we apply to the data to get these process behaviour limits. And there are rules that Alison will cover later in terms of when something statistically changes. But it's a really powerful way to be looking at your data and really important in your large-scale change efforts. This is a more recent example. This is looking at data for IAPs, and this is from a trust board report, which is 179 pages long. So I would suggest that as a board member with a lot of papers to have a look at, you might skim past this presentation of data because it's all green, and therefore surely everything's absolutely fine. We took the last 3 items on this table and we put them into control charts recently. And let's have a look at what lies beneath. So if we look at those 3 indicators that were all green over a period of months, what we can see is that for the middle indicator here, which is IAPT treatments within 6 weeks, although the threshold, the target, is just still being met, we can see that there's been a deterioration over quite a significant number of months. And we can see that the coloured dots there indicate that there has been a statistical change. So just by plotting the dots and applying some process limits, we could have made a different decision and we could have made an intervention much earlier rather than sitting on our laurels and thinking that absolutely everything was fine. So another example, this is data that's produced by the Department of Health on a monthly basis. And again, we're looking at A&E performance data here. And I've changed the names to protect the innocent. So we've got 5 trusts that are named as the most improved and 5 trusts named as the biggest decline trusts. So I wanted to focus on Pleasant Surprise Trust. So they were in the most improved category. They moved from 73.1 to 77.3. So they weren't in the position of getting a phone call from NHS Improvement demanding an action plan. You know, why did that data go down this month? So let's have a look at their data in another way and what happened prior to them. So here's where they were the most improved. And this is what happened before. So again, we can see that over a period of time, the performance has been deteriorating. We probably didn't notice this as an organisation. I don't know if the trust did. So SPC is a really good way to enable you to A, know when to go and ask some questions and make an intervention, but importantly as well, to look at whether the interventions that you're making are having the desired impact. So until I got this job, I wasn't familiar with the vast body of academic research evidence that says that you make a better decision if you do use an SPC chart. Shipman was identified as a result of using SPC analysis, as were a number of other GPs that were struck off as a result of that analysis being undertaken. This was a publication from many years ago. There are lots and lots of publications, and I'm going to come on later to tell you where you can get hold of them. My experience still is that we don't see SPC used in terms of analysing health data that much still. And in terms of what my role is about, it's about trying to drive the system to be better at using data and to use SPC to analyse data to inform decision making. So this is one of the few lovely examples that I've stumbled across on my travels. It's done in Sheffield, and this is looking at length of stay for frail elderly patients. So the green lines that we can see on the graph are those control limits. So we can see that at the start of the graph, there was a lot of variation in terms of how long you might expect to stay in hospital as a frail elderly patient. So just above 3 days to 8 days. There was then a change that was implemented, which resulted in quite a significant reduction in variation and length of stay. Towards the end of the graph, which had a very, very, very dramatic impact in terms of reducing that variation again. From my experience, we still all too often assume that the changes that we're making are having the desired impact, and we're not very good at actually measuring the indicators that we should be looking at to see whether that energy and effort that we've put into a change has made an impact. And for your large-scale change efforts, this is going to be fundamentally important, and hopefully you've been doing some of this work to date in your projects. So NHS Improvement have recently developed something called the Emergency Flow Improvement Tool. You can access this whether you're working for a commissioner or a provider, so you need to contact me for more details on that at the end if you're interested. I'm sure that Ian will circulate my contact details. So here we are seeing a range of indicators that track patients through arrival at an acute hospital, indicators that look at timing points through A&E, indicators around admissions, and then discharges. These are all SPC charts, and you will notice that we're not using red or green as colours because they're colours of judgment. So each of the graphs there has got an indicator title, we've got some benchmarking, we've got a latest activity value, and then we do have those control lines. So we can see a mean line and the upper and lower control limits. What we're trying to do here is educate people about how to react to data without getting into the intricacies of all of the SPC statistical rules. So here, if we can see grey dots, that's to be expected variation, and we shouldn't react to it. Whether it's gone up or down, it's to be expected. We don't need to do an investigation. If we're seeing orange dots, it means that something has changed and something needs to be investigated. So it might be an increase in waiting times. It's something that you need to act upon because you need to understand what's happened and you need to take mitigating action. If we see blue dots, that's also special cause variation, but actually it might be something positive that you can learn from. So it might be a reduction in waiting times, and you might want to understand how has that reduction been achieved. So we made this available to trusts on, I think it was the 7th of September. We've had really good feedback on it so far, and we're seeing some really good examples in terms of being able to evidence where interventions have had an impact. So we've had various discussions with trusts across the country to understand the local context in terms of their data. So here's a trust that we saw a very marked reduction in average duration to initial assessment in A&E. And what we know from speaking to the trust is they created a new post to expedite assessment. And for 10 months, there was a very, very marked reduction in terms of that timing point. Something has happened subsequently. I don't know what that is, whether it was a fixed-term post or somebody's gone sick, or people are just assuming that that improvement is being sustained. I don't know. but now we're presenting data back to trusts that enable them to go and have those conversations. We're learning that in the main, people aren't looking at data in this way, and the feedback is that it's enabling them to have much richer conversations. So I'm hoping that I'm doing a bit of a sales job here in terms of why you should look at your data in this way. A lot of the feedback that we've had from people working in the NHS is, well, this is all well and good, but actually we haven't got an analyst that can help us look at data in this way because they're too busy feeding the beast of NHS improvement and NHS England. So one of my team recently developed an SPC tool. So here's a screenshot of it. It's very easy to use. It is designed to be used by frontline staff. You basically put in the organisation's name, how many data points you're going to be looking at. Then there are dates that auto-populate on the left-hand side of the screen there. And as you key in your data, basically the dots get plotted on the graph, and the rules, if triggered, come up in different colours. So you can see towards the end of a graph there are some turquoise dots indicating that an SPC rule has been triggered. You can also type in where you've made an intervention, and these will appear on the graphs at the relevant points. So if you haven't got a tool that enables you to look at your data in this way, you can download this tool, have a play with it. We've had some good feedback so far, so I'm going to come on to in a minute how you can access that. So I have established a community of interest. I don't know if any of the participants on this call are members of that community, so I put out a tweet in April saying, does anybody want to be part of a Measurement for Improvement community? And I had 100 people come back to me within the space of a week. Quite remarkably, that has now grown to over 600 people. So it's an online community. I've tried to pull together all of the resources that I'm aware of, whether it's those published papers that I've referred to, whether it is the set of toolkits on how you do measurement for improvement. Some of these might be quite old. They might be old Modernisation Agency publications or NHS Institute publications. I've pulled them all together rather than reinvent the wheel and just rebadge something. We have got a number of discussion items underway at the moment, and over the past week or so, we've probably had kind of 50, 60 people contribute to discussions online, and people are sharing different approaches that they're using. So I'd encourage you, if you are interested in this stuff, to join the community. If you want to join, you need to just send me an email. My email address is there. We held 2 national events just at the end of November with 100 participants at each of them, talking about how we can make measurement for improvement mainstream. So I've got a lot of rich feedback as a result of that, and we'll be planning our activities here at NHS Improvement for the next year as a result of that feedback. In terms of the free SPC tool that I've referred to, you can download that from this virtual community. So there's a section under resources that is called something like QI templates. You can download the SPC tool there, and there's also a little video that you can watch just to take you through how to use it. For next year, we will be planning a series of webinars focused on topics that people are particularly interested in. I think the first one is going to be looking at what kind of language should we be using around statistical process control. The technical language scares people off. Most people don't need to know the technical side of things, although some people do, and Alison's going to talk about that in a bit. So watch this space and come on board to make the revolution happen and plot the dots. That's my sales pitch, really, and the thing that I just wanted to finish by saying is that having gone through the Academy for Large-Scale Change, what I've now reflected on is it's just the way that I work now. So I had a conversation with Ian a week or so ago. In terms of coming into this new role a year ago, I've applied those same Academy for Large-Scale Change principles. So I've had a plan for what to do, but I haven't spent 6 months developing a plan. Got on and delivered stuff, delivered a tool which is hopefully helping trusts solve a big area of priority, so maybe boarding the train of challenges around A&E. And I think as a result of the experience of the Academy, it's just become the way that I work, and I really genuinely hope that it has the same impact upon you and that it influences how you work, not only in this project, but also moving forward. So at that point, I'm going to hand over to Alison.
Thanks, Samantha. Okay, hi there, I'm Alison. My background is, as Ian already said, is as an analyst, and for many years I was one of those very exciting analysts who've been producing lots of statistics for the NHS, lots of big tables, lots of incomprehensible charts, no doubt. And then I went and worked for the Treasury for a few months. I did some work there, and was given a project where I had to present some, create some slides for some very senior members of Parliament. And it really was, for me, it was a bit of a boot camp for measurement for improvement. It really made me have to think a bit more differently, to step away from those big charts. And I think once you've done that, once you realise that you need to be presenting things more simply and move away from big long tables into simpler ways of presenting things like run charts, like SPC, I realised I couldn't then go back to publishing lots of tedious tables and statistics. So Sam has shown us the light about using data over time and not being too hung up about 2-point differences. So I'm going to walk you through some of the steps that you can do, whether you're involved in management, whether you're frontline staff, whether you are an analyst yourself. I think it's something that everyone can be involved in, and it's useful for everyone to have a certain understanding about measurement for improvement, because you can't necessarily assume. Certainly, for a long time, I was one of those analysts who didn't understand the differences. So it might be useful to point them to some of the community of interest resources that Sam's highlighted there, if you find that the people that you work with aren't familiar with them either. So I'm going to talk you through some steps that you can do to help you choose your own measurement for large-scale improvement programs. So let's go back to some of the ingrained ideas about why we actually measure. So if you've been working in the NHS or social care, you'll be very familiar with performance measures. They tend to be for very strategic senior management, of the public even. It's all about accountability and whether or not the quality of the work that we're doing is good. It's usually very large sample sizes, and it's a census, so it's all the data that we have. And it can be several years or even decades worth of data. Also in the NHS, we're really commonly used to things like clinical trials, measurement for research purposes. It's usually a clinical audience, and we're trying to discover something new, using things like randomised controlled trials or clinical trials to find out if the new thing that we're interested in is better than the existing treatment. Again, we've got really, really large, statistically significant samples, thousands and thousands of patients. Things take several years to run. But then we've got measurement for improvement, which is fundamentally very different. The model for improvement is based around doing lots of little mini experiments, constantly testing new ideas and measuring to see which ones work and which ones don't. This is usually a largely internal audience. These might be lots of little things like adding a new member of staff or changing a process. So it's very much quick and dirty data that we're interested in. We're just interested in finding out whether a new way of working is better than ever before. So we're looking for just enough data, frequent data points over time. And rather than years of data or several thousands of patients, what we're really looking at is things that take place over several weeks and months rather than years. So the good news is that we just don't need that same volume of information. And that hopefully will make it a lot more accessible to most people when they're looking at improvement work. So when we're thinking about measurement in terms of large-scale change, there are 4 assumptions here that I've taken from the large-scale change guide. So first of all, it's worth remembering that the problem that you think you have is not as unique as you think it is. So it's always worth asking other colleagues in other organisations to find out about the problems that they've had and find out what they've done. You might find out that they have some ideas about what they've already done. You have more data than you think. That's almost always the case in the NHS. So don't forget that we have things like admin data, clinical audit data, lots of survey data. You don't need to collect something very specifically for improvement work. You can use things that are already available. So speak to your project management office, speak to your analysts, and find out what is already available. You probably need less data than you think. Have you done a logic model or a driver diagram? Use that, and it should tell you which things are most important about your program of work. So you just need to measure those things. There is a useful measure that is much simpler than you think. So ditch the complex indicators. Ditch the complex things like mortality indicators, readmission indicators, those sorts of things. They are very highly technical measures which are useful for things like research or judgment when you're comparing your trust with other trusts, for example. But it's just not needed for improvement work. So the great thing about measurement for improvement is that you're no longer concerned with what's happening elsewhere, particularly. You're just fighting your own fight. So just be pragmatic and use the measures that are easy to gather, quick to analyse, and easy to make decisions with. So a single measure on its own doesn't tell us anything terribly useful. So we need to collect a family of measures so that we can get a better handle on the bigger picture. So we've got the three phases of measurement, but we've also got three types of measurement. So outcome measures reflect the end result of healthcare interventions. So they're related to the people and the things that happen to them. If you've got a logic model, you'll have a number of outcomes already listed. So you should be measuring those things. So they can be things like mortality rate, hospital-acquired infection rates, patient experience. Then we've got process measures, which should reflect the work of the system. And they are usually the measures of things that you're trying to change directly, so things like staff, facility, resources. They can also be things like waiting times and the proportion of patients given treatments, for example. And then we've got balancing measures. We're using balancing measures to look or detect things that are maybe influencing the outcome of our outcome or process measures. So it might be things like case mix, how sick the patients are when they present. It could be factors that increase or decrease the number of patients, such as a flu outbreak, and the availability of other services. There's lots of little other things that might be influencing your outcome and process measures. So we've got a quick quiz just to see whether or not you're paying attention and to start to think about what sort of measures we might be using. If you take your cursor and take it to the top left-hand corner of the window, you should see a little pen button and it says annotation. So you can click that and scroll down. You might have come across this already. You click on annotation and then you'll see a little arrow that's pointing to the right-hand side. And if you click on that, you'll get this icon. I don't know if you can see that. Rachel, if you turn that on for us. If you do that, I'd like you to vote with your arrow and tell us which one of these is correct. Oh, very good. Number of hospital beds available in your local hospital. So do we think it's an outcome measure, a process measure, or a balancing measure? We've got a mixed thing there, but I think a lot of people here are saying it's a process measure. What do we think? Yeah, absolutely. Friends and family test. Would you recommend this service to a friend or family measure? Do you think it's an outcome measure, a process measure, or a balancing measure? Yep, I can see we're getting a lot of responses there. A lot of responses. That's fantastic. Yes, it's an outcome measure. It's all about the patient. So percentage of A&E patients being seen within 4 hours. So it's quite a tricky one because it's about patience as well. But absolutely, it's about process. So a percentage of A&E patients who could have been treated at home or in primary care settings. What do we think? Well, it was a bit of a tricky start there, but I think we've all got there in the end. Absolutely, it's a balancing measure. If we have a lot of patients who could have been seen elsewhere, then obviously that could well have a big impact in our ability to handle the workload in accident and emergency. So an exercise we quite often like to do when we have a training event is to think about how would you write measures about measuring a banana. As you can see, a banana is quite a tricky thing to measure. So it's useful to practice this skill with something quite tangible, because often the things we measure in health and social care are very abstract and complex. So all of our measures need to be relevant. It should give a communicable meaning to a concept that we're interested in. Ideally, it measures the exact thing that we're interested in. If we want to know if bananas from Latin America are longer than bananas grown in West Africa, then length is a good measure, for example. A measure should be clear and use unambiguous language so that someone else should be able to read your definition and repeat it to be able to get the same results. You might need to think about testing a measure with someone else or using measures which you know have been tried and tested. Your measure should also be a good measure for quality. For example, we know that a banana with a consistent yellow colour all over is a reasonable way to determine if it's good to eat, and one which is green might be underripe and brown spots might indicate overripe. So that's quite a reliable way of measuring something. You also want to think about how many measures are necessary. Think about the burden of time and effort of gathering your data. And with improvement work, don't forget it's okay to stop measuring once you've found your improvement. Sam's already touched on this. If you could reduce the message to management in just a few words, I'd say it was all to do with reducing variation. What we're really talking about here is this. You start off with a lot of variation, and then as we move forward, you can see that these confidence limits here are getting tighter and tighter. So as we start to make an improvement in our service, we get less and less variation. So what do we mean by variation? So the definition is a slight change or difference in condition, amount or level, typically within certain limits. But we've got two types, and Sam's already touched on them as well. So you've got things that show normal variation, such as the number of baked beans in a tin, or the distance I can throw a paper over a plane. It's usually known as common cause. It's the natural random variation that we experience day to day. It's that kind of up and down noise that we see on charts. But then we've got things that show unusual variation. It might be things like the number of vehicles on a road during a special event, like a music festival, or maybe the waiting time at a post office when one member of staff is training. So this is known as special cause, when there's something that's non-random or special or new, has changed the normal passage of events. So why are we interested in this? What does it really mean? Well, real data has lots of noise, and what we don't know when we look at it is whether that is down to normal variation or unusual variation. So we have some tools and techniques that we can use to help us understand whether what we're seeing is normal or whether it is unusual. So let's think about what we've got here. So on the left-hand side here, we have an example of natural variation. If we were to weigh this collection of men and women, we'd get a range of weights. However, if we introduce somebody like Arnold here, who's eaten and trained specifically to add lots of muscle mass to his body would get quite an unusual result. He's introduced a special cause variation to our group, and it's doing something different. In a healthcare setting, you might find that you've got special care variation by doing things like add a new member of staff, by changing your appointment allocation process, or perhaps by changing training regimes for staff. So let's do a little quiz again, using our arrow pointers. So again, get your pointers from the top left-hand corner. How many patients arriving at A&E on a Monday? Do we think that's common cause or special cause? That's right. I think everybody's got that. That is very definitely a common cause. So what about if we're thinking about how many patients arrive at A&E on a Monday during a bank holiday? Absolutely. We think that's special cause because we know that something different is happening. We know that other services are likely to be shut. So it's quite reasonable to get a bump of people visiting A&E on a Monday during a bank holiday. If you're a GP, how many minutes might it take you to see a patient who's presented with a cold? You might expect a certain amount of time it would take to see a patient. And again, that's likely to be common cause on a normal day-to-day. Of course, this is the NHS, so there may be the odd case where we've actually got some special cause in there. People who present with a cold might actually have some other underlying issues. So when we've got lots of data, Sam showed you earlier, we've got lots of big tables, and it's really useful for us to be able to think about visualising that. So when we're visualising data, what we're trying to do is we're trying to summarise the data in a way that tells us a story, in a way that tells us what's happening, because lots and lots of numbers don't really tell us what's happening. So I'm just going to check that you've been listening and ask you to vote again with your arrow pointers to tell me which of these 4 charts do you think is most useful when we're thinking about measurement for improvement. Absolutely. Yeah, I think you've got it there. You've done a good job there, Sam. People have been listening. Yes, absolutely. We've got line charts. So I just want to really quickly talk you through some of these, what are the key features of a line chart. I think what we really want to see is it's really, really simple. Line charts are something that we can do even without any technology. If you have some simple data available to you, you don't need to have any particular technology or particular pieces of equipment. This is something that I just drew, as you can see, even without a ruler. So the key features that we want are titles. We want to have an x-axis going across the bottom showing time, and then a y-axis across the left-hand side showing the thing that we're interested in. Then we draw our dots, and then we just connect them with a line. You've got a median, which is the middle value. You might need a calculator for this, but that's fairly simple to calculate. And then what we do is we look for signals that tell us that something new or interesting is happening. Now, I'm not going to go through these run chart rules in any detail today. We've got some information here that you can come and have a look at that will take you through that. But what really the run chart rules do allow us to do is that these are really simple rules that can be applied by anybody. You don't need any software to be able to apply them or to be able to understand them. As you can see here, we're just counting the number of runs or points above the line or in consecutive directions. So it's actually really easy and straightforward to analyse and to understand what's happening in a run chart. But it still has statistically significant results. And again, the same thing applies to statistical process control charts. So this is the two side by side. So the main features are that a run chart has obviously the X and the Y axis, and it's the same for the SPC. And we have lines of data that are connected. You've got lots of data points that are connected by lines. We have a line through the middle. For a run chart, it's a median, and for a SPC, it's a mean. And for an SPC, we have these two lines above and below, which are the upper and lower control limits. But fundamentally, you can see that they're actually very similar and aren't very difficult to produce. And of course, if you do want to use an SPC, I very much recommend that you go to Sam's Cahoots group and get access to that tool, because it does make it really, really easy to apply. So putting it all back together again, what does this really tell us? How this fits in with the model for improvement. So first of all, you need to plan what you will be measuring. Use the aims from your logic model or your theory of change to choose some outcome measures. Choose process measures for the new interventions you're going to try, whether it's new staff or whether it's new tools or techniques. Then you want to think about capturing balancing measures for other or unintended outcomes. And of course, write your family of measures into a measurement plan. Then you want to try out some ideas or interventions to see if they work. Run lots of those little mini experiments to see if it works. And capture data as you go to study or to check to see if there's a change in your outcome measure. And finally, you actually make a judgment on the data that you've gathered, choosing which things have worked well and which things you want to include into your normal program of work. So we've got lots of resources that will help you to do that. We've already looked at some of those today. Ian, are you going to talk people through the various resources that we've got as part of the guide?
Can do, yes. The measurement part of the large-scale change guide has got some links which you just popped up here onto the screen, which can take you to places where you can find out a little bit more about using some of the tools and techniques that have been described today, and some of them take to places where you can find out a little bit about what kind of data might be available as well. Not just purely quantitative stuff. The framework for patient experience has got some really interesting stuff and some really good tips about engaging with patients to understand from their perspective what makes their experience a good one or a less good one, and how we can capture some of that and use that in our improvement work as well. And I think, if I might, Rachel's just popping the links for those into the chat box, so they will be clickable and you can grab them too if you want to check those out at another time, or you can come across onto the collaboration space where we've got all of our resources, which has got a link to the large scale change guide, which has all of this in. So I think that brings us to the end of the presentation part. So I'm very keen to see whether or not folks have questions for Alison and Sam on measurement, large scale change, or measurement of large scale change within your own challenges, projects, or pieces of work that you are looking to progress. So if you have anything, do pop it in the box. If you're feeling particularly bored, you could also raise a hand and we'll see if we can unmute you and you can put your question directly to Alison or Sam.
Right, Ian, before people ask questions, I just wanted to say that I've already had quite a few people email me asking to be members of the measurement community, so that's fantastic.
Excellent start.
Welcome,
and
people.
Have you got them in it already before the end of the webinar?
Yeah, they've already all had invites.
Invites already, excellent.
Oh, another few coming in now. I'll send you invites straight after this, so hopefully we'll be up to 700 people soon.
Well, excellent. It sounds like you're all busy joining into Sam's measurement community to get access to the curated and collated resources that she has put together. But I'm not sure anybody's asking a question yet. Stunned into silence. It's my favourite subject in this webinar series, measurement as well.
See, they're all converts already. Yeah. I think they want the journey already, so this is all good.
Possibly.
But just to add, in terms of, I've already put a message on the chat box, but the invite to the measurement community will actually come from a Cahoots email address, just watch out it doesn't go into your junk email, because that does sometimes happen. And if you don't get an invitation come through, just contact me again.
Okay. There is some good stuff in that measurement. Oh, Alison, hello.
Sorry, I was just going to say again that if anybody's interested in that SPC tool that Sam's team have created, it's incredibly useful. It's incredibly easy to use, and all you need to be able to do is just literally type your numbers into the spreadsheet, and it creates the lines for you. It even provides you with some information about how to interpret it. If there's not a lot of data, if it's still quite an early time series, it creates a run chart, and when you've got enough data, it'll produce the SPC for you without you having to do anything specific to it. So it's absolutely brilliant, and I'd recommend it to anybody, really.
Okay, excellent. We've got a couple of questions coming through. So we've got one from Tara's asked a question about how can we access the emergency flow improvement tool?
Okay, so for people that are working in trusts, they have access to something called the model hospital. So people that are working in trusts can gain access to that tool via the model hospital. If people are not working in trusts, they can also access the tool. There's a separate email address that they need to email, which actually I could probably quickly look up before the end of this and put it in the chat box.
Okay.
So I will look at that one now.
Splendid. Got another question. I quite like this one. Darren asked a question. Any techniques to engage people when they don't like looking at data, as if such people exist?
There are people like that. I think my experience has got an absolute solution. But one of my reflections over the years is that the data becomes much more powerful and more engaging if it's actually linked to a story. So my advice would be start with the story and support your story with the data. I find that that's much more engaging with people that aren't actually particularly interested with the numbers. So you get them hooked into the story, and the data, of course, is important in evidencing that story. So that would be my advice on that one.
I completely agree with you there, Sam. I think quite often people who don't like data think that they don't like seeing large, complex presentations of data. And I have to kind of agree with them, actually, on that. There is a great resource that I've been sharing with folks. And there's a book, there's a website, there are videos, there's whichever medium that you particularly like using, by a lovely lady called Cole Nessenbauer-Naflick. I can never pronounce her name. Miss Baumer-Naflick? Yes. Anyway, I'm just putting the link in the chat box, but I'd really recommend that you go and have a little look at that. It talks you through some really simple things that you can do to improve how your data looks. So it's really about stripping it right down, making it easy to read, making it easy to understand, and some good tips there for analysts and non-analysts alike for how to tell a story with information. And as Sam says, it really is about the story, it's not about the data. So you should just be using the data fairly lightly to be able to illustrate the points that you're trying to make. So I would heartily recommend going and having a look at this particular website and having a look at that book.
Many thanks, Alison. I hope people find tips in there that help to address that question. We've got one more. We'll try. We'll see if we can get a view from both of you on this one as well. So, a request here: do we have any examples of data that has driven large-scale improvement?
Ooh,
it's a good one, isn't it?
It's a good one.
It will probably be our last question as well. So. A deep, insightful answer from your good selves would be fantastic.
I haven't got any that are immediately springing to mind. We need some.
We need some examples of how data is driven large scale.
Oh, Shipman, yes.
Yeah. Oh, there you go.
That's a great example, actually.
Exactly. That, for those of us old enough to remember, was a massive shift in how primary care is organised based on what happened in that case. And I believe you presented it to us, Sam, the paper that Mohammed and co worked on, which used this type of simple analysis to really kind of mark out the differential in mortality rates for that particular GP. So I think there we go. It's a very good example. It might be the only one we've got today by the types of things.
I can see that somebody else has already suggested their children's cardiac surgery. I think there are lots of examples of where data has been used in the media, in the press, things like 7-day services, things like that, where data has been used to highlight an issue. And what we don't often see, as certainly in the press or certainly in the public domain, is when things are starting to change and when things are starting to move in the positive direction. So I think it's an important point actually that quite often we'll see the data that makes the case change, but we don't necessarily always see the data that proves that things are in a better position. And that is partly the problem, that when things are better, we kind of forget about them and move on maybe. I don't know, Sam, what you think about that.
Well,
yes, no, I agree. But it would be good if we pulled together almost a library of things like this, because there are some great examples, but we probably have forgotten a bit about them. So I think that's something for me to take away and have a think about.
Something that we are doing within the Sustainable Improvement Unit, the Sustainable Improvement team within NHS England, is that we're starting to develop impact stories where we use data and we use a narrative to be able to tell the story of some of the large-scale programs that we're involved in. So things like 7-day services, like primary care, where we are making some huge changes. It's still too early, I think, for us to be able to share some of those stories. We're just starting to share some of them with NHS England, with a wide audience within NHS England. But I think that's a really important point, actually, that we probably need to be putting that out there.
And it's just got me thinking, Alison, that perhaps in the future we can think about doing a webinar around the impact framework approach, and that might be very useful for people to adopt into the large-scale change approach as well. So I think we're almost out of time, so we've got a couple of little things to do just to round out the session. First of all, many thanks to both Alison and Samantha for joining us today and sharing their insights on why to measure and how to measure. A much under-considered but important part of large-scale change, I believe. But then the three of us are all big enthusiasts for it, so we would say that. So finally, if you've not yet joined into the collaboration space we have for the Virtual Academy on NHS Networks, please do so. It is the place where you can find all of the resources for not just this webinar, but all of the preceding ones as well, including video recordings of the sessions so that you can recap or catch up on anything that you may have missed. If you haven't got any problems accessing that network, please do get in touch with Rachel, who will be happy to help you get on. I know a few of you have had difficulties. I hope you are all on there. The numbers are growing all the time. We haven't quite reached the heady heights of Samantha's network just yet, but we are not quite as mature as Sam's community space on measurement just yet, but hopefully we will be able to catch up. And finally,
Ian, just a quick one for me, just jumping in on there quickly. Sorry, just to say, I've put the email address in the chat box for the emergency flow improvement tool, and also I've had about 60 people already email me about the community. Over to you, sorry.
Excellent. Thank you very much. Yes, do join into Sam's community as well. It is very much focused on measurement rather than large-scale change per se, but the resources that have been curated in there are very, very good. So final thing from us before we go, what's coming next? There won't be a webinar next week for the Virtual Academy. We've reached the last of the six sessions. We are planning some large-scale change and system leadership masterclasses in the new year. They are all now fully booked. We've been overwhelmed with the response. I hope that I will meet some of you there. There are certainly names in the expressions of interest that I recognised from this webinar series, so I hope that I bump into some of you on some of those events, we'll be letting everybody know the outcome of the expressions of interest process. More masterclasses needed. Well, hopefully in 2018-19 we could offer some more. We don't yet know. We've certainly got the ones to deliver in Q4 yet, but if there's demand and we can do that, we'll certainly let everybody know that that there are more available as and when that happens. Fully booked for now. Hope to see many of you there. If you haven't got places on there, or even if you have and you are interested in more, particularly around mobilising and working with New Power, Old Power and change, our colleagues in the Horizons team in the new year are also launching again their School for Change agents, and if that is something that floats your boat, I can heartily recommend it, by the way. Then you can register for the school on the link in the box there too. Is it, Tara, is it too late to express an interest? Unfortunately it is, Tara. We were oversubscribed as it was, and we are basically completely full. As Bridget says, can we do some more? If we can, we will, but it probably will not be until into the 2018-2019 financial year, with us having January, February, and March fully booked up. But it's great that people want to do that. We would love to work with as many people as we can. So it's fantastic to hear the response to that offer. So it brings us to the end. Many thanks for joining us, not only on this webinar, but all of the preceding 5. I hope that it gives you a good start in your large-scale change work, and I hope to meet some of you over the coming months. So I think that is it for us. Just remains to say have a great day, and for those of you who are into the December thing, do have a great Christmas and New Year as well. Many thanks, people.
Thank you.
Thank you, Sam, as well, indeed, and Alison for joining us yet again to do it. Thanks very much, folks. Have a good day.